All right, so I'm going to go ahead and do a separate lecture on pneumothorax. I thought I covered it in the other recorded lecture, but I think what I did is when I recorded it last year, I actually taught this part in class. And so since I didn't get to this with you guys, I'm going to just give you a whole separate lecture. If I already covered it in the other lecture, I apologize, but pneumothorax is important. It's something I want to make sure that we do cover. So in a pneumothorax, you have air or gas that's going to accumulate between that parietal and that visceral pleura, which is going to cause the lungs to collapse. And the amount of air or gas trapped is going to determine that the degree of the lung is going to collapse. And so when you express that a patient has a pneumothorax, they'll say what percentage of it is collapsed, okay? In some cases, we're dealing with venous return to the heart that gets impeded because we're dealing with such a large collapse. That is a life-threatening condition called a tension pneumothorax, and I'll get to that part in a second. So a pneumothorax is going to be classified as either a traumatic or a spontaneous one. A traumatic pneumothorax is going to be further classified as open, or what we call a sucking chest wound, or closed, which is a result of blunt or penetrating trauma. So an open or penetrating wound may in turn cause, a closed pneumothorax if communication between the atmosphere and the pleural space itself seals. The spontaneous pneumo, also considered closed, can be further classified as primary or secondary related to, some other cause with it. So the pathophysiology of pneumothorax is going to vary according to the classification. So your open pneumothorax is going to result when atmospheric air, or the positive pressure, flows directly into the pleural cavity, or the negative pressure. So as the air pressure in the pleural cavity becomes positive, the lung is going to collapse on that affected side. And the lung collapse will lead to a decreased total lung capacity. And that's where that patient is then going to develop a ventilation perfusion imbalance, which leads to hypoxia. So for a closed hemothorax, that occurs when air enters the pleural space from within the lung, which causes an increased pleural pressure and prevents lung expansion during inspiration. It may be called the traumatic pneumothorax when blunt chest trauma causes lung tissue to rupture, which results in air leakage. So that would be like if your patient hit their chest on a steering wheel, for example, during a car wreck. That would be what would I be talking about there. Now, the spontaneous pneumothorax, that is a type of closed pneumothorax, and the usual cause is rupture of a subpleural bleb. Okay, a bleb is a small cystic space on the surface of the lung. This rupture causes air leakage into the pleural spaces, and then the lung collapse, causing a decreased total lung capacity, vital capacity, and lung compliance, and that in turn is going to lead to the hypoxia. So here are the types that I was just talking about. So again, you can see at the top, that's that spontaneous pneumothorax. That is actually really common in very tall, lanky men. Okay, so if I always think about like those big, tall basketball players, like very, very tall. They can just spontaneously get a pneumothorax. B, that's what I've got as a traumatic pneumothorax. So as you can see, the knife is penetrating into the lung, and that would cause the lung to collapse. And the very bottom picture, that is your tension pneumothorax, where air is going to accumulate and can't escape. And so what happens is like on inspiration, that mediastinum is going to shift towards the unaffected lung, which will further impair ventilation. And then on expiration, the shift distorts the vena cava and is going to reduce venous return. That is all cardiac in nature, but a tension pneumothorax is definitely a medical emergency that has to be taken care of very quickly. So what are you going to see? So spontaneous pneumothorax may not produce symptoms in your very mild cases, but you're going to get a profound respiratory distress in your moderate to severe cases. You may see a weak and rapid pulse, pallor, jugular vein distension, anxiety. All of those can indicate a tension pneumothorax. But for most cases, you're going to see sudden, sharp pleuritic chest pain, asymmetrical chest wall expansion and movement, shortness of breath, cyanosis, decreased or absent breath sounds over the collapsed lung, and then you may get crackling beneath the skin on palpation. We used to call that subacute emphysema. It's also known as crepitus, and that actually feels like Rice Krispies under the skin. And then, like I said, for your tension pneumothorax, because we're dealing with more cardiovascular compromise, you're going to see late signs of deterioration like a tracheal deviation, which means the trachea is not midline like it's supposed to be. They'll have decreased venous return, which will actually slow down that heart rate. So you'll have bradycardia. You can have cyanosis. And if this is not treated, they will go into shock and they will die if you don't get this quickly resolved. So diagnostic tests, we want to get a thorough history and physical exam. This sometimes can be considered an unstable patient, as I've kind of mentioned with the symptoms. So we could bring an ultrasound to the bedside so that the patient didn't have to leave our monitoring devices. A chest x-ray, that can show error in the pleural space and it may reveal that mediastinal shift. And then if this pneumothorax is significant, your ABG findings could indicate a pH less than 7.35, a partial oxygen pressure less than 80, and a partial CO2 level above 45. So you could definitely get some respiratory changes, definitely some respiratory compromise, and those will be reflected on your ABG levels. So treatment is conservative for your spontaneous pneumothorax in cases where there's no sign of increased pleural pressure, the lung collapse is less than 30%, and the patient shows no signs of dyspnea or other indications of physiologic compromise. So your treatment is going to consist mostly of bed rest or activity as tolerated by the patient. We're going to do careful monitoring of blood pressure, pulse, and respirations. We're going to administer oxygen. In some cases, needle aspiration of air with a large bore needle attached to a syringe. Also keep in mind that when more than 30% of the lung has collapsed, re-expansion of the lung is going to be performed by placing a thoracotomy tube in the second or third intercostal space at the mid-clavicular line. This procedure is done to allow air to rise to the top of the interpleural space, and the tube is going to be connected to an underwater seal with suction at low pressures, and that's that chest tube that we have talked about. A recurring spontaneous pneumo is going to require a thoracotomy. These procedures prevent recurrence by causing the lung to adhere to the parietal pleura. A traumatic or tension pneumothorax is going to require a chest tube drainage system. And then a traumatic pneumothorax may also require surgical repair because we're dealing with cardiovascular issues as well. Nursing care for this patient, we're gonna assess our patient. We're gonna watch for pallor, any gasping respirations, any sudden chest pain. You're gonna carefully monitor vital signs at least every hour for indications of shock, increasing respiratory distress. You're gonna listen for breath sounds over both lungs, okay? A falling blood pressure with a rising pulse and respiratory rates may indicate a tension pneumothorax, and as I've mentioned, it's fatal if it's not promptly treated. You want to make your patient as comfortable as possible. So a patient with a pneumothorax is usually most comfortable sitting upright. You want to urge the patient to control coughing and gasping during a thoracotomy, so during that chest tube insertion. After the chest tube is in place, you want to encourage the patient to cough and breathe deeply at least once per hour to provide lung expansion. If the patient is undergoing chest tube drainage, you want to watch for continuing air leakage, like bubbling in the water-sealed chamber. This can indicate that the lung defect has failed to close and may require surgery. You're going to observe for increasing subcutaneous emphysema by checking around the neck or at the tube insertion site for any crackling or that Rice Krispie feeling beneath the skin. If the patient's on a ventilator, so if we had to intubate, be alert for any difficulty in breathing in time with the ventilator as you monitor for gauges as the pressure increases. You're going to change dressings around the chest tube insertion site as needed. Don't reposition or dislodge the tube. If the tube does dislodge, we talked about this the other day, you're going to immediately place a petroleum gauze dressing over the opening to prevent rapid lung collapse. You're going to observe the chest tube site for leakage and note the amount and color of the drainage. We can walk the patient as ordered, usually on the first post-op day, to promote deep inspiration and lung expansion. You want to make sure that you reassure the patient by explaining what occurs with the pneumothorax in cases and all accompanying diagnostic tests and procedures. And I can't reiterate this enough, you always evaluate your patient. How are they responding to your interventions? They should have normal chest x-rays, respiratory rate, depth, and vital signs. Okay, these are all things that we want to make sure that we teach them. And if you have any new changes, any new changes in your vital signs or appearance of your patient, you're going to report them promptly to the RN or to the doctor. All right, that's going to wrap up pneumothorax. Make sure you guys go back over components of a chest tube, you know, what's normal, what's abnormal, because that goes very closely hand in hand with the pneumothorax.